Okay, this is week 7, recorded lecture, chapter 27, newborn risks. So the first thing we're going to talk about is how do you know you have a newborn at risk? So you determine that by the age of the woman, because someone who with advanced maternal age or a teen could possibly have problems, their babies could possibly have problems innate to their age. And then parity, how many times have they been pregnant? Some of the complications that can occur, of course, are the abruptio placentae, oligohydramnios, preterm labor, premature rupture of membranes, preeclampsia, as well as many other things, but these are some of the most common conditions that place the baby at risk. So just as a reminder about gestational age, so preterm is anything less than 37 weeks. Term is anything above 37 weeks to 41 completed weeks. Now they have term broken down into late preterm and post term. I'm sorry. For preterm, they have it broken down into late preterm, which is 34 to 36 weeks. Now, this group, late preterm, presents a special set of circumstances for the baby because they generally do quite well initially right after delivery, but then you send these 34 to 36 weekers home, and that's when the problems start to develop when they're not in the hospital. So a lot of education with these parents on things to look for problems that are starting to develop. The term, again, is 37 to 41, and then the post-term is greater than 42 weeks, and we generally don't see that anymore. We might see 41 and 5 weeks being induced, but generally physicians don't let women go beyond 42 weeks. Because that placenta actually starts deteriorating around 40 weeks, just depending on how healthy it was to begin with. It doesn't live forever. It won't function forever. So these babies are at risk for placental insufficiency the longer they go post-term. Now, I just wanted to kind of give you a look. This is a 31-weeker, and you can see the skin is very thin and wrinkly. They don't have a lot of body fat. This baby is actually in an isolette, so temperature stability is a big issue for these babies. Not only do they not have a lot of body fat, they don't have a lot of brown fat. And brown fat, when it's metabolized, increases their core temp. So double whammy for these babies. Now, this is the macrosomy baby. So this is the baby that is large for gestational age or over 4,000 grams. And these babies can have a whole set of problems. They look all cute and snuggly, and you just want to squeeze all their little fatness, but these babies can have a lot of problems. And if you see in the little description here, this baby's only 38 weeks. And it weighs 3,400 grams, so big beefy baby at 38 weeks. Now, I'm showing this picture. This is a post-term baby, so you would think a post-term baby would be this big fat, large baby that's been growing forever and ever. But what happens is that placenta starts deteriorating. This baby at term, who was probably 7 pounds and nice and fat and all that kind of stuff, is now starting to lose weight in utero. So that's why you see all this saggy, wrinkly skin and this little old man looking baby. Really, really dry skin, like like if you've had your hands in soap water or something like that for long periods of time, you get wrinkly skin, and then they get really dry. So that's what a post-term baby, this is the problem the post-term baby can have. So it starts losing weight. Okay. Now, when we talk about gestational size, so there's an appropriate size for each gestational age. So when a baby is born at 36 weeks, there can be an appropriate weight for that baby. Now, at 36 weeks, that baby can either be small for 36 weeks, or it can be large for 36 weeks, or it can be appropriate. So large for gestational age is designated as LGA, appropriate for gestational age is AGA, and small for gestational age is SGA. Okay? If a baby is born at 36 weeks and appropriate for gestational age, that's all fine and dandy, but baby was born at 36 weeks. Now, a lot of these things will have to do with their respiratory status, and their blood sugar status, and their thermal regulation. So those are all things that we're looking at, and gestational age and taking their temp are things that we can do routinely. So there are many protocols that will state if you have an AGA baby, an LGA baby or an SGA baby, you will be doing frequent vital signs and frequent blood sugar checks. Okay. All right. Now, small gestational babies, we determine that when we plot their weight on the graph. And if they are below the 10th percentile, and there is a line that designates for their age what the 10th percentile is for their gestational age. So if they're below the 10th percentile, that they're considered SGA. And then a lot of people say IUGR, intrauterine growth restriction. It's actually two different things, okay? So intrauterine growth restriction, yes, you are going to be having probably a small for gestational age baby, but intrauterine growth restriction is more about growth and development than weight. SGA is only about weight. Intrauterine growth restriction is more about growth and development, okay? And they divide in IUGR into symmetrical and asymmetrical. And it would be better to have a baby who was IUGR asymmetrical than it would be to have a baby who was IGR symmetrical. So what that means is asymmetrical, that means that their head is disproportionately bigger than their body if it's asymmetrical, okay? So they've got this really big head and they've got this small body, okay? Why is that better? Well, because as the baby developed in the first trimester, everything was going normally. Baby was developing normally, okay? And then in the second trimester, somewhere in there, something probably went awry and development kind of slowed down. Well, the head is already normal size now, but the rest of the body that's still developing is now not developing according to the baby's gestational age, okay? So the insult happened later in pregnancy, okay? If the baby is IUGR symmetrical, that means that there's a problem from the very beginning. So as soon as this baby started growing and developing, problems were already beginning, okay? So symmetrical is definitely, the baby has had problems longer and is going to end up with those problems when it's delivered, okay? Now, complications that you can have, your baby can have when your baby is SGA is fetal hypoxia, aspiration syndrome, hypothermia, we already know that, hypoglycemia, we already know that, and polycythemia, okay? These babies that are SGA, you know, have uteroplacental insufficiency, so there is your hypoxic situation, and then their aspiration syndrome. So usually babies that are small, you know, are having some sort of distress in utero, and then we worry about their aspiration meconium at delivery. Now with IUGR, we're talking about development problems, so we might have some congenital malformations. It might have been caused because of a uterine infection. We have growth and cognitive disabilities, okay? So these are growth and development problems. with an IUGR baby as opposed to your SGA baby who's having, you know, is not putting on weight, not getting nutrients from the placenta, and having those kind of problems. So, so your baby, if for whatever reason is being born preterm, and with preterm babies, you have all these, you could have all these problems with your baby. So apnea of prematurity. So their central nervous system is not mature enough to automatically be breathing as normal. So this baby may have periods of apnea. Now, if you ever have a test question about apnea, babies are irregular breathers. They do have pauses in their breathing. So apnea has to be greater than 20 seconds. Okay, they have to not be breathing for greater than 20 seconds to have apnea. Okay, we've talked about patent ductuses. So your baby is born prematurely. They're not having adequate respiratory effort or respiration or gas exchange, which continues to keep the pulmonary vascular system constricted, and that's why we have the patent duct. Okay, respiratory distress syndrome is different than childhood or even adult, because this is directly related to surfactant. Okay, so they start producing surfactant in the later part of gestation, 35 weeks. They start piling on surfactant. If they're born premature, they haven't started that process. And remember, surfactant is the product that helps keep the alveoli opened after expiration, so that their little sacs do not collapse after they've blown out their breath. Okay, and preterm babies are predisposed to that. Any babies that have any type of aspiration, blood, meconium, amniotic fluid, those things can deactivate surfactant. So double whammy there. Intraventricular hemorrhage is related to the vasculature, their vessels in their brain are not mature enough and strong enough to tolerate really anything. So a delivery, depending on how preterm they are, delivery could be enough of a stressor on the vessels in their brain to cause hemorrhage. Okay, positioning, depending on how preterm they are, could set them up for a bleed. Hypoglycemia and hypothermia and respiratory distress can put them at risk for an intraventricular hemorrhage. Okay, and you know, all other kind of problems like their gut, like necrotizing enterocolitis is a big risk for preterm babies. Their gut is not ready to start processing food, and you know, they may have infection going on. So there's all kinds of things that can happen to your preterm baby. You've got to be ready for everything, and you've got to be checking everything. And this is why they're probably in the NICU. Okay. All right. Diabetes. So usually, most of the time, babies of diabetic mothers are born larger than you would expect for a baby at their gestation. So they're probably over the 95th percentile on the weight plot. So that makes them LGA. And any large baby, whether diabetic or large for gestational age, is going to be at risk for hypoglycemia, because they're getting these buckets of glucose from mom, and they're producing the insulin to handle that glucose level, and then the cord is cut, and now they're not getting that glucose load anymore. So the insulin that they're used to producing now drops their blood sugar. Okay. You get SGA as well with infants of diabetic mothers, because depending on, especially if they had chronic diabetes, not gestational diabetes, but they had chronic diabetes before pregnancy, if they already have vascular problems to begin with, then those are going to continue in their pregnancy and then set them up for uteroplacental insufficiency throughout the pregnancy. So you'll have an SGA or even an IUGR baby. So, oh, birth trauma. So, yeah, definitely birth trauma because you've got this large baby trying to be delivered vaginally, and sometimes it just ain't gonna happen, and she ends up going C-section. Polycythemia, hypocalcemia, hyperbilirubinemia, all these things, RDS, congenital malformations. Congenital malformations are more so related to the diabetic woman who was uncontrolled before pregnancy and continued to be uncontrolled during pregnancy, is very traumatic to a developing fetus. So we could end up with some very severe congenital malformations, some that are incompatible with life, and some that are so severe that the pregnancy is, she loses a pregnancy, before 20 weeks. So we want to make sure mom's on good glucose control. When she's in labor, we'll actually be checking her blood sugar every hour. And then the babies, of course, we'll be putting them on the 24-hour glucose checks as well. And we may even be infusing some level of glucose for both mom and babe during labor. Moms are usually put on, in labor, a D5 solution. So in labor, we always run LR on our pregnant patients. But if she's diabetic, she'll probably be put on D5 LR. And we may even be running insulin at the same time. So it's a tight wire act. With moms in labor. And then babies, if we have babies that are having hypoglycemia, hopefully we just are able to feed these babies and everything is fine. But if their blood sugars are very low and we can't get them up or we can't keep them up, these babies may be on IV glucose. So on babies, let me see if it's in my next slide. So on babies that so they're admitted to the NICU if they end up with IV glucose. They are given D10, period. It's no D5 for babies. It is D10 across the board. We can give them a little 2 cc per kilo bolus over a 15 to 30 minute time frame, and then put them on a maintenance of 80 per kilo per hour, and then we'll be checking their blood sugars often, and they're in the NICU at this time. And if their glucoses are extremely difficult, we can go up to a 12.5 dextrose solution, but nothing ever greater than 12.5 through an IV. The highest we will ever go with our dextrose solution would be D15, okay? And that will only go through a UVC, a uterine vein catheter, okay? And then D15 is the highest you ever go with babies. Never D25, never D50, okay? All right, so I mean that was just a real quick brief overview of the baby, of the infant with a mother who's diabetic. Okay, so hopefully these babies are born and they can stay on newborn nursery, breastfeed these babies, or if they're bottle feeders, of course we'll bottle feed the babies, and hopefully that maintains their blood sugar. And usually after 24 hours, babies are their insulin production has normalized and they do fine. However, some of them need to go to the NICU for IV glucose. Okay, so your post-term newborn. So this is your baby born after 42 weeks. Hopefully the placenta has done okay through that time and they're born appropriate for gestational age. You may have a large baby because it's been in there for 42 weeks. But remember back the picture I showed you at the beginning of this slide presentation of that baby who looked skinny and wrinkly and dry, flaky skin. So that was a placenta that was deteriorating to the point where baby wasn't getting nutrients and started losing weight. Okay, but if you have a baby that is 42 weeks, and even if they're appropriate for gestational age, 42 weeks is a big baby, and then they may be large for gestational age, you're going to have problems with a vaginal delivery. So you'll have cephalopelvic disproportion, and mom's just not able to pass to push baby through, or you'll have a shoulder dystocia. So you get the big old noggin through, and then you get the shoulder hung up behind the pubic bone, and that is an obstetrical emergency. Okay, with shoulder dystocia. With shoulder dystocia, then the nurse and the physician will do some procedures, some techniques to try to release that shoulder. I don't know if it was your lecture or the PN's lecture that I discussed the different maneuvers, but the first maneuver that is tried, besides the fact that you're going to have a person on each one of mom's legs and you're going to be pulling her knees back to her shoulders to really open up her pelvis, okay? And then if that doesn't allow the shoulder to be delivered, then the nurse stands on a stool so that her body is above the mother, okay? You ball up your fist and you put it on her pubic bone. Okay, so that's right where the shoulder is stuck. You put it on her pubic bone and you push down, and the physician will tell you which way the baby is facing. So you push down and towards where the baby is facing. So what you're trying to do is you're trying to collapse those shoulders anteriorly on baby, almost folding that baby, okay, shoulder to shoulder, so that that diameter can now slip through the pubic bone, under the pubic bone. And this puts the baby at huge risk for clavicle fracture, brachus plexus injury, nerve injury. We could fracture a humerus. You know, we could do some damage with baby trying to get the shoulder dystocia relieved. And then there's some other things that the physician can do internally, like he can try to slip his fingers in and hook that shoulder, or hook underneath the armpit and fold that shoulder down, try to maybe twist baby around to get that baby out. And there have been times where these babies just we have not been able to get that shoulder through. Okay, so this is where it becomes the obstetrical emergency. Actually, it's the emergency before, because you know, baby might not be breathing at this point. The cord may be pinched by now, and baby's not getting anything. Okay, so that baby's got to get out. But if that baby cannot get out, I mean, like I'm telling you, that there have been times where we could not get that shoulder delivered. So what? You can't leave the baby sitting there the whole time. It's not coming out. There is no way like we could get that baby out. We have rushed with the head sitting on her perineum. We have rushed to OR and had to deliver that baby. So this is really, really, really scary stuff if this happens. Okay. All right. Now, hypoglycemia, same with LGA, diabetic mother, SGA babies. They can have a potential for hypoglycemia. Meconium aspiration, oligohydramnios. So everything starts, the baby is under stress, and when babies are under stress, their gut relaxes and they pass meconium in utero, and then they have a huge risk of aspirating that and getting meconium aspiration pneumonia, which is really, really, really bad. Polycythemia, congenital anomalies for post-maturity syndrome. Now that may not be related to the fact that she's the post-maturity is not the thing that's causing the congenital anomalies. These babies that are post-term likely already have a congenital anomaly, okay? So it's not her being post-dates that makes these babies have congenital anomalies. So seizures, probably related to some sort of hypoxic environment because the placenta is deteriorating, okay? And then cold stress because they're using up all their brown fat and their ability to metabolize that brown fat for to keep their temperature up, and as well they may have been losing weight in utero, so they're losing all their subcutaneous fat. Okay, so these babies are born, they have really dry, cracked, flaky skin. Okay, there's no vernix on there. Vernix is that cheesy stuff that babies that cover baby's skin in utero. The more preterm a baby is, the more vernix they have on their skin when they're delivered, and the more term they are, the more that has absorbed. Okay. So anyways, you can see long, thin body with loose skin because they've been losing weight. Okay. And then meconium staining. So their skin, the umbilical cord, their nails, depending on how long that meconium was in utero with them, they can actually get stained. Their skin, their umbilical cord can be stained green. Okay, so a lot of things to look for, to watch out for, even a post-term baby. Okay, so your preterm infant. Now, why do they have the respiratory problems? Well, immature lungs and inadequate surfactant production. Remember, I said surfactant is what keeps those little alveoli opened at the end of expiration. Okay, their vascular system, especially their pulmonary and their cerebral vascular system, is not mature. Those vessels are very fragile. Okay, and then because of the respiratory problems, the problems with their gas exchange, they're not getting the correct transition to neonatal circulation from fetal circulation, so their the pulmonary hypertension and the pulmonary vasculature vasoconstriction continues post-delivery, which is what contributes to the patent duct. Okay. All right. As babies start getting close to term, then they start taking all that glucose that they have, and they start storing it in the liver in the form of glucagon. Okay, the brown fat starts developing around the internal, centrally, internal places like the axilla, the clavicles, sternum, around the kidneys and things like that. And that brown fat is what they utilize what they metabolize to create their thermal regulation. So preterm babies don't have those things going on, so they have decreased ability to stabilize their temperature. Okay. Now, with preterm babies, they have very thin skin. The blood vessels are close to the surface of the skin, and as that warm blood goes rushing through those vessels, then they lose heat through their skin, through the vessels that are close to their to the skin surface. And then their body surface, their skin surface ratio to their body weight, so they have a bigger area in which to lose heat. Preterm babies, they don't have good flexion in their extremities, so when a baby's born, they're all flexed, their arms are bent into their chest, their knees are bent, and they're just like a ball. Okay, so they're flexed. That's a normal newborn position. But with a preterm baby, they don't flex. They just lay there like a Raggedy Ann doll, and that exposure also increases their risk for temperature problems. Okay, and then so this decreased ability to vasoconstrict, so that's kind of related to the heat loss with those blood vessels close to the skin surface. So these babies have a poor, preterm babies have not developed their gag reflex fully yet. So they're, you know, that sets them up for actually a aspiration type deal. But you know, their GI, everything from their GI, from their esophagus down, is not fully developed. So you know, they have poor suck swallow coordination, so they're not able to take PO very well. So these are the babies that we might need to be tube feeding or some type of parenteral nutrition. And then, you know, if we do happen to feed their gut, then their gut might not be mature enough to process feedings, and then they might have, you know, necrotizing enterocolitis or something like that. So GI wise, they're still very not ready. Okay. Absorption of their nutrients, they're not able to do that yet. So you know, if we are feeding these babies, even if it's with a tube, the contents of their feedings are very much calculated and planned according to their gestational age for optimal nutrition and to decrease the chances of any type of absorption problems. All right, so a lot of this we've already spoken about for their GI. Now for their kidneys, again, these babies are premature. Excuse me. So their kidneys are premature, so their excretion and their filtration is going to be impacted, okay? And this is especially a concern if you're giving this baby drugs for any reason. So we've got to be really careful on our doses for these tiny kids. And then their immune system. So they're not building up immunities, especially if they're not taking breast milk. They're not getting those type of immunities. So these babies are at huge risk for infection. And then you've got these babies with this really thin skin, and you can start damaging the skin, just like an elderly person who gets these skin tears. You can harm the baby's skin, which opens them up to infection that way, but they start losing, you know, plasma volume, serum, and all that kind of stuff through these weeping, oozing wounds on their skin. So they do a lot of crazy, cool stuff in the NICU to protect these babies and their skin. Neurologically, they're also not fully developed, and like I said, their blood vessels in their brain are very delicate, and they're at huge risk for a brain bleed. Okay. Now, when they decide about feeding these babies, you know, they base it on their gestational age and what their system can tolerate as far as absorption. These babies may end up having to be on TPN of some sort if their gut is not mature enough to process the nutrients they need to grow. Okay, and a lot of times, even if we do have them on some type of PO feeding, they will have some sort of, you know, we might be adding vitamins and things like that to their feedings. Now, with premature babies, if they are on a PO feed of some sort, so their gut can tolerate feedings, we need to decide what the baby is physically able to do. So is the baby able to bottle feed? Is the baby strong enough to be able to suck and swallow for the entire time of the feeding? Okay, that's one issue. And can they coordinate their suck swallow? So babies suck, 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 and then they stop sucking and they swallow and then they breathe. Okay, so they've got to do that. They got to coordinate that so they don't aspirate. And preterm babies, if they're having any respiratory problems at all, especially if they have tachypnea, this can be a real challenge for a baby to suck, swallow, breathe. It might be too much. It just, if they're breathing too fast, then they're not able to suck, 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 swallow before they have to take another breath. So these babies may be gavaged fed. Now, breastfeeding would be great. They still need to do the suck, swallow, breathe, but they need to be strong enough to suck. So sometimes these preterm babies are just not strong enough to breastfeed. Okay, so you can put a bottle in a baby's mouth and it takes little effort to suck on that bottle nipple and get food coming out, because it pretty much just drips out at a very slow pace. But breastfeeding, you have to suck, and you have to suck strongly in order to get a feeding. So these preterm babies may not be strong enough to breastfeed, and then if they are strong enough, can they do the suck, swallow, breathe coordination? So we do end up gavage feeding these babies a lot. Sometimes we will gavage one feed and bottle or breastfeed the other feed, or do 2 gavages with 1 breastfeed as we increase the strength of this baby. And then as soon as we can get this baby on straight bottle or straight breastfeed, the better we are. So when you gavage feed a baby, we do the same thing as with an adult. We check placement of that tube. Is usually indwelling. So if you have a baby that is being gavage fed for a 2-week period, you don't want to be passing that tube 20 times a day for 2 weeks. So you put the tube down and you leave it in place. But for each feed, you need to check placement. Okay, so some facilities have a protocol on what they consider appropriate methods of checking placement, and usually the 2 are so we take a little syringe with about 1 cc of air, we hook it up to the gavage, we place our stethoscope over the belly, the stomach, and then we quickly push that air in so that we can hear it in the stomach. And then the second thing we do is we aspirate from the gavage tube and hopefully have some gastric aspirate to tell us, yes, we are in the stomach. And then also, depending on how much you aspirate, so if you fed the baby 2 hours ago 10 cc's of breast milk or formula or whatever it was, and 2 hours later you confirm placement, you're in the stomach, and you aspirate, if you aspirate a whole 10 cc's of stomach contents, that baby did not digest that previous feeding, and baby has a gut issue, and you don't need to be feeding this baby anymore, okay? Or at least you need to skip the feeding. So it'll be the physician who decides. Maybe this baby needs to go back on NPO with TPN or something like that. So, and then if you feed the baby 10 cc's every 2 hours and you aspirate 4 cc's, then maybe this feeding you only give the baby 6, okay? So we try to make sure that we're not giving too much feeding for this gut to process, but we're giving enough feeding for the baby to grow and get strong, okay? So there's all the spiels for the feeding. All right, I am going to pause for just 1 moment, and I will. Okay, hydrocephalus. This is a genetic defect, a neurotube defect, and can cause a lot of birth trauma. Hydrocephalus is the brain is, the brain is filling up with fluid, cerebral spinal fluid, for whatever reason caused this neural tube defect, okay? Babies born with a neural tube defect will have a large head. Their brain will be full, okay? So just as when babies are born and the skull molds, so those sutures are not fused, they're able to compress, they slide over each other, okay? You also have the ability for the for it to get larger, okay? So as it fills up, depending on how severe this hydrocephalus is, you know, the head can become very large. So I'm going to show you a picture of this, and it's going to be hard to see from my picture, but if you Google this, like, this is real stuff. Like, I'm telling you, go Google this and look at hydrocephalus. Okay, do Google images and look at some of these pictures. They are literally not even, don't even look real. These are real people, real babies, real children. Hydrocephalus is not something that is specific to newborn babies. People with severe meningitis or some sort of cancers, they can do this. Okay, other things as well, I'm sure. But go look at some pictures. Okay, but anyways, if you have a baby born, you know, you're going to have enlarged or full fontanelles. So you know, you have the anterior fontanelle and you have the posterior fontanelle, and we check those on our babies. Okay, and they're supposed to be flat and soft. Okay, so just a little flat and soft. Now, if they were sunken, okay, if they were depressed or sunken, then that's a dehydration, anemic type issue. Okay, but if they're full or seem like they're swelling, then something's causing that, and that is extra fluid of some sort. Okay, and so those sutures, those spaces between their cranial bones, they start widening as the skull has to expand for however the amount of fluid is starting to accumulate. Okay, anyway, so when you do these assessments, then we do head circumference measurements. Okay, and then yeah, if it's greater than 90 on the growth chart, but we will be doing serial head circumference measurements and watching how this you know, documenting and assessing how much this head is expanding. Okay, I'm sorry, I should be on the slideshow. Okay, so so we measure the head circumference daily, and actually we're probably gonna, this baby's probably gonna be in the NICU, and they're gonna probably be doing head circumferences every 4 to 6 hours. Okay, they'll be doing ultrasounds to see, maybe see if they can see if there's a structural problem that's causing this. You know, you position these babies and provide padding and cushioning for these heads. Okay. All right, and so we may end up going to surgery with these babies and putting in a shunt. Okay. And this is just, you know, not a drastic picture. You can see this head looks kind of big and misshapen. And then you can see from the little diagrams, the normal brain on the left there, you can see the difference in how things look like they're filling up on the right picture, and this just expands and expands and expands. And I'm telling you, go look at some pictures on Google. Okay, I put this picture on here because it wasn't as traumatic, and I mean, it's, you look at those pictures on Google and you're just like, this can't even be real. The size of these children and these babies, the size their heads can be. Okay, so go take a look. All right, choanal atresia, that is a blockage in the posterior nasopharynx somewhere. Babies are nose breathers, so if you have a baby that's born with a choanal atresia, they're going to have immediate respiratory problems. Okay, one side may be blocked, both sides may be blocked. So depending on the severity of this blockage, will tell you. So these babies need they need an airway. Okay, if you're, you know, if the blockages aren't significant, you know, and you're not sure whether we have a choanal atresia, you can try to pass a tube and see if you can get past the posterior pharynx, and then of course X-ray will tell you definitely for sure. So we need an airway for this baby. We need to keep the baby's head elevated. and maybe even provide some sort of supplemental oxygen until surgical remedy is performed. And this is what it looks like. So right here is your blockage. So it's a bony, cartilagey blockage of some sort. So this should be open right here. All right. So this is a problem. Cleft lip and palate. So a baby may have just a cleft lip. A baby may have a bilateral cleft lip. And baby may have an intact lip but a cleft palate, or both. Okay, cleft lip and palate. So when your baby is born and you're doing your thorough assessment, then you will check. You'll put your finger in your baby's mouth because you're going to check for your suck reflex, but you're also checking the palate, especially on a baby whose lip is fine. You want to make sure the palate is fine as well. So depending on the extent of this cleft, they will have difficulty sucking. So if they just have a cleft lip, they will probably be able to have enough suction where they're not having a break in their suction to be able to feed. Depending on the severity, especially if it's through the palate all the way up into the nasal cavity, if that's the case, these babies will have no ability to create suction. Okay, they do have special nipples that help for bottle feeding. We may end up doing gavage feedings on this baby until there's a surgical repair, and then their swallowing may be impeded as well. But if these babies have a severe cleft palate, then they could be getting formula. They don't suck and they can't swallow it. They can't get it to the back of their throat to swallow it, so it comes up out their nose. So they're going to have aspiration risks. They're going to have breathing problems. So these babies need usually to have surgical repair. Okay. Anyway, here are some of your nursing interventions. And then here's some pictures of, so the first picture on the left, of course, is the normal. You can see there's no break in the palate or in the lips, okay? So in the middle picture, we just have the cleft lip, and you can see that the palate is mostly intact. The bottom picture is a little deeper cleft lip where it does extend a little bit into the palate. But the picture on the right, so this baby has a bilateral cleft lip, okay? The second picture, it's not into the palate, it's just the lip. But the third picture, you see that big black empty void space. That is a cleft palate extending all the way into the nasal area, okay? Now, tracheoesophageal fistula, and I wished I would have put atresia, fistula atresia. So a fistula is, if you remember, a fistula is an abnormal attachment of some sort of tube, okay? It's not the correct route. It's not the correct attachment or opening, or however you want to describe that. The atresia is a blockage, kind of like the choanal atresia where there was a blockage. An atresia is a blockage, okay? So when we're talking tracheoesophageal, that's what we're saying is the the esophagus does not go from the mouth to the belly. It has been blocked. Actually, what usually occurs is development doesn't complete. So there's not a continuous passageway from the mouth to the belly, okay? It stops. It's halted, okay? That development stops before it gets to the stomach. The fistula happens when there is a connection or a communication between the trachea and the esophagus, okay? So depending on, and now there's several different types, several different ways this can be put together, okay? It can be just a fistula with an intact esophagus. It can be, well, I'll show you pictures of all the different ways this can be put together, okay? So the problem is with oral secretion, so if we have an atresia where there's a blockage, there's no way for oral secretions to be swallowed to the gut. Okay, so they just back up and then they end up getting, you know, they end up coming up. So if you're trying to feed this baby, the food is not going to get to the stomach. It's just going to start, you may get a feeding in. Okay, you may do one feeding and you get it in and you think, oh, everything's okay. Then you do the second feeding, and depending on how deep that blockage is, if it's a very shallow blockage, you might start, you fill up that esophagus pouch where it has abnormally closed, and you fill that up, and then it starts spilling over into the mouth and or down the trachea, okay? And then if you have the fistula, you know, you may get the feeding that goes down, but if that baby burps or spits up, then that feeding comes up, and then part of it diverts from the esophagus into the trachea and where? The lungs, okay? So anyways, those are the problems. So if you're thinking that you have some sort of esophageal atresia, you'll try to pass a tube down to the stomach and you won't be able to get past. There's a blockage. It stops. It doesn't get to the stomach. If you have a fistula, you don't necessarily, you can't really pass a tube and say, oh, I have a fistula. Okay, so we'll look at some pictures so that you can kind of see that. Some more nursing intervention. So we really need to protect this baby's airway, do everything we can to prevent aspirations. How do you do that? You keep the mouth suctioned of oral secretions, and you do not feed this baby, okay? Okay, so keep the head elevated, and then we're going to be doing IV electrolytes, maybe even TPN, okay? So this is what they look like, okay? So in this first picture, right here is the esophagus. So you see it formed only to there, okay? So no food is going to get to the stomach from there. So as you feed this baby, it's going to start collecting into this esophageal pouch, and then the more you feed, the more you start spilling over out the mouth and down the trachea, okay? Now, here's the rest of the esophagus, and this is the fistula right into the trachea. So any gastric aspirate is going to come up the esophagus and dump right into the trachea, okay? Here in this picture is we have the esophagus that has the fistula right into the trachea, okay? It's an atresia and a fistula. This is an atresia and a fistula, okay? This is the atresia part where the two do not grow. They're not one, it's not one continuous esophagus, and this is the fistula, okay? Here's your atresia, and here's your fistula, okay? So here's another different way this can form. You've got your atresia, but you got these fistulas from both ends right into the trachea. So here you have a complete esophagus, but you have a fistula into the trachea. This picture you have no fistulas, you just have the atresia, okay? And then here, this crazy looking thing, you really don't have a trachea. You have an esophagus with a trachea growing off of it. So there's no trachea. Right here's where the trachea is supposed to attach. Okay? All right. So there's all the different ways this could be. Okay? Now, how do you repair these? Well, one, you disconnect this fistula into the trachea in any of these. Okay? But what about you've disconnected the fistulas? How do you get the esophagus put back together. Well, hopefully you have enough tissue, you can connect these and anastomose them together. But more often than not, there's not enough tissue to connect these. So over weeks and weeks and weeks and months and months and months, they are waiting for this to grow so that they make it, so that it grows enough they can connect it. And a lot of times, I don't know what the procedures are called, but a lot of times they'll put weight on this part right here, or they'll extend the tissue and wire it up and do all kinds of crazy things to help stretch it and to promote this growth so that they then connect it. So this baby will probably end up having a G tube, a PEG tube, right into the stomach for feeding. Okay? All right, diaphragmatic hernia. Okay, this is where there's a defect in the diaphragm and the gut, the bowels, end up going through the diaphragm and invading the lung cavity. Okay, so this is going to create, so when this baby is born, you know, a lot of times they see this on ultrasound, and then this baby is born, and this baby has this really huge barrel-looking chest and this sunken scaphoid-looking abdomen, because there's nothing in there. It's all in the chest. Okay. If you listen to breast sounds, you will hear them on the right and not the left. Okay. When you listen to heart sounds, you'll hear it on the right and not the left. Why am I saying right? Why are the guts not going up into the left side of the chest? What's blocking? What's between the chest and the gut on the left side, on the right side? It is the liver. So when you do have this defect, the liver is on the right side, so the guts aren't getting through that way. They're getting through on the left side. So the guts are in the left lung cavity, and you have this, depending on when this happens, you have this aplastic, atrophic left lung, and then you have this, the heart pushed over to the right side of the chest, and everything is on the right side, and the lungs and the heart on the right side, and then the gut on the left side. Okay. So, so these babies are going to have a hard time breathing because they really only have one lung that's working. So you're going to have to help them breathe, and usually 99, you're going to put a tube, airway, you're going to intubate this baby, okay? You're going to intubate this baby because you want the air that you're giving the baby to go right directly into the lung, okay? So if you did any type of CPAP or positive pressure ventilation on this baby, you're pushing it down through the mouth, the posterior pharynx, and then whatever air does go into the lung, the other air is going into the stomach. Okay, well, the stomach is sitting in the left chest. Okay, so that stomach is going to start swelling and causing even more problems for the remaining lung. Okay, so we need to, one, have this baby intubated so that air is going straight into the lungs, and two, you're going to want a tube, an orogastric tube or a nasal gastric tube, usually an orogastric tube, right into the stomach to keep air out of the stomach, to keep the stomach decompressed. Okay, and then they're going to need surgical intervention. So here is on the left, here is the normal setup of internally. You have lungs on both sides, you have the heart in the center, you have the big old liver there, you have the stomach kind of right below it, the diaphragm between the lungs and the liver, and then the guts down there. But here in the picture on the right, you see that that you have bowel up into the left chest cavity. You have a little bit of liver up there as well, and here over on the right side you have the heart and this little itty bitty tiny lung. Okay, look, even all the vessels, the pulmonary artery, the aorta, everything is shifted. Okay, so we need to get that fixed right away. Okay, an umphalocele and a gastroschisis. Okay, very similar things. The umphalocele is when you have abdominal contents or the gut that has, there's another defect in the umbilical cord where the abdominal contents kind of are in the umbilical cord, okay? It's this big, huge mass. It's covered with a sac, okay? And it's in the umbilical cord. Now the gastroschisis comes through right beside the umbilical cord, usually on the right, and it's not covered in a sac, so it's just exposed bowel, okay? And of course, both these things need fixed as well. So you can see these on ultrasound, and then you have this baby delivered, okay? So we need to keep them hydrated and maintain their temp. So, you know, an internal organ is on the outside of the body, not on the inside of the body where it's supposed to be. So what happens is we lose heat that way, right? And so we need to keep this baby this baby hydrated, but the internal organ part hydrated as well. And one way we do that is we put these babies in a plastic sack or wrap them in cellophane, you know, around their abdomen, okay? We need to keep their gut decompressed. We're not feeding these babies. We need to prevent infection. We're starting antibiotics. They're probably getting, you know, a D10, and this is what they look like. So on the left, we have the gastroschisis. You can see that we have bowel not covered in, you know, the lining of the umbilical cord. It's just exposed bowel. It's on the right side. It's not really in the cord. And on the right here, we have the umphalocele. It's contained within the umbilical cord membrane. That is bowel, the same as over here, but it's enclosed in the sac. Okay? All right, and you can Google this picture as well and see some really interesting pictures. All right, prune belly. I've actually never seen this in my practice. This is where they have so their abdominal wall is not developed to whatever extent. Okay, it might be partially, it might be totally. They do not have an abdominal wall. Okay, so these bellies, the bellies on these babies, like, you know, we will joke around and say, oh, look, the baby, you know, just looks like I have a little frog belly. That's a frog belly on steroids, a prune belly. Go ahead and Google these. These look amazing as well. These can be full and distended, or they can just look like a big wrinkly mass of skin, okay? So this is another, maintain their respirations, you know, prevent trauma to the internal body organs. You know, we're going to place a urinary cath because they probably have urinary problems or urinary tract problems as well. So this is a good picture of a prune belly, but they can be a lot larger. This one looks very full. Some of them can look really quite saggy. So take a look at some of those pictures on Google, but you can see how big this belly is. Okay. All right, myelomeningocele. This is a neurotube defect. Hydrocephalus is a neurotube defect, but a myelomeningocele is a sac of spinal fluid and spinal cord outside of the body. Okay, so we need to prevent trauma and infection to that site. We need to keep the baby off their back and on their belly. Excuse me. We need to keep them clean. We don't want stool and urine coming up on that, okay? And let's see some pictures of this. So, you know, this is a big one right here, this baby right here, okay? You know, when we look for the dimple or the tuft when we're doing our initial newborn assessment, it can be as minor looking as this, like it's a tuft of hair, or maybe it's a little dimple, like just like a little dimple in the skin, or it could be an actual opening that we can see in. But then we have a meningocele where we just have this sac of spinal fluid kind of protruding up through here, or we have actual cord in there, okay, and that's a myelomeningocele, spinal cord, okay. Oh shoot, I'm going to pause for a minute because I have this is a neurotube defect, and I thought I put the other slide in here that had some more pictures, so I'm gonna put us on hold here, and I'm gonna go grab those pictures. So I'm gonna pause. Okay, so here's this slide. Here's all different levels of neurotube defect. So the spinal cord into the brain, that's all neurotube, okay? So here is those meningoceles in their different stages or different types, okay? But as far as the brain is concerned, there's these different formations as well. Anencephaly they're missing part of their skull and part of their brain. And cephalocele, the meninges of the brain are forming through a defect and extending out here, okay. This crazy looking thing here, I have never seen this, but you know, these are crazy looking things, okay. So I just kind of wanted to show you that real quick. Anyways, let's move on to our last slide. Okay, so these are birth-related things for babies. Okay, so neonatal asphyxia. So we've talked about this extensively. Hypoxic events for the fetus, and then, you know, here you got a baby born, and you know, even if they didn't have any problems in utero, so they can develop problems after birth, okay? So as far as circulatory things, so we expect baby to go from fetal circulation to neonatal or newborn circulation, and for whatever reason, they're not transitioning. They're not doing that. So they're staying with what they call persistent fetal circulation. And if you can kind of remember, fetal circulation, basically the big deal here is when blood comes from the placenta to the baby, it's already oxygenated, okay? So as it goes through the heart, it doesn't go from the right ventricle into the pulmonary circulation and then get a bunch of oxygen and then come back to the heart, the left side, and then out through the aorta to the baby. Okay, so or to the rest of the body. It doesn't need to do that in the fetal circulation because blood is oxygenated from the placenta. So it bypasses the lung and goes to the body. Yeah, a little bit goes to the lung, but basically that's oxygenated blood going to feed that organ. But as far as feeding the body with oxygenated blood, it doesn't go through the lung. So when this baby is born, if this baby continues to have persistent fetal circulation, that means that the blood is still going through that fetal circulation where it's bypassing the lungs. So we're not getting any oxygenated blood pumping through the body. Well, it's not like we're not getting any. We're just getting very little, okay? So this baby is in a persistent hypoxic state. Okay? So anyways, so there's your circulatory problems. Your respiratory problems is, yeah, I mean, this is one of the reasons why we stay in the persistent fetal circulation. Is the baby is not breathing well enough. The baby is not expanding its lungs. It's not taking in oxygen, which causes the gradient in the pressures in the pulmonary vasculature. Okay, so we still have this constricted high pulmonary pressure, okay, which is contributing to our persistent fetal circulation. So it's a vicious cycle, okay? So as this fetal circulation continues, as the baby is not taking in adequate breaths, so baby's going to start breathing faster to try to get that oxygen, and then it's just not going to happen, okay? So then we start contributing to hypoxemia. So hypoxemia is decreased oxygen in the blood. We're not going to be blowing off our CO2. We're going to be going into anaerobic metabolism, which is going to create, we already have respiratory acidosis because we're not breathing right. We're not taking in oxygen. We're not blowing off CO2. All the CO2 is staying in our bloodstream. It's contributing to metabolic acidosis. Now we're going to be having brain damage and cell death and then death. Okay? So this is all bad stuff for babies. Now we can anticipate having a bad baby if we have bad heart rates on our fetal monitor, okay? So like if we're having decelerations, or if we're having minimal or absent variability, okay? Or if we're having a bradycardia, if our baby has a sustained bradycardia, okay? Then we know that we're probably going to have a bad baby. The more difficult the labor is, the more prolonged the labor is, the more we can anticipate having a bad baby. We can do a fetal scalp pH. They don't do these routinely. I actually have never worked anywhere that does these, okay? Fetal scalps. Actually, I can't say that. We did these back in the day, but these are not helpful. These are not as helpful as we wanted them to be. This is different than, I don't know if I told you the story about doing oxygen, fetal oxygen saturations, where they put in the little oxygen saturation probe that they try to place on the baby's temple area or cheek, and they're measuring oxygenation in utero. That's different than a fetal scalp sample of blood to test for pH. But anyways, we don't do these pHs anymore. They're more risky than they are helpful. You know, the amniotic fluid, you know, there's all kinds of things that can skew the test results. So we're basically relying on our history, on our fetal heart rate tracing to prepare us and for delivery, and we're just going to be prepared, okay? So usually what we do is, if we have a bad baby on the monitor after baby is born, then we'll collect a cord gas and test for pH that way. But it's not going to determine what we do or don't do. We're already going to be ready for a bad baby, and we're already going to be performing any type of resuscitation we need to do, despite what that gas is going to tell us, okay? But anyways, if we get serial blood gases, the one thing about blood gases for babies is these babies are in the NICU, they're probably on a ventilator of some sort, and we're using these gases, these serial blood gases, to help us with our ventilatory settings, okay? Anyways, that's kind of beyond us right now. But anyways, so what other things can tell us that we're going to have a baby that's going to probably need some resuscitation is a woman who has meconium-stained amniotic fluid. We can anticipate that our baby is going to need support afterwards. If she has some significant bleeding during labor, or throughout her pregnancy. It might tell us that we might have a bad baby. If we're delivering prematurely, we pretty much anticipating a bad baby. If we've decided we have an SGA baby, if a baby is born with congenital anomalies that we did not detect during ultrasound, this baby is probably going to have resuscitation. If our mom had oligo or polyhydramnios, those might give us some indication of some problems with baby. All these things, you can read these. All these things are going to tell us that we might have a baby that needs some sort of resuscitation at delivery. Now, so we can do our blood gases. This says before birth. So our pHs of less than 7.2, our baby has been asphyxiated. If it's less than 7, we have a severe acidemia. Okay. Again, fetal heart rate is going to tell us that. If we do some sort of fetal oximetry, which we don't do anymore because there's not a reliable fetal oximetry equipment to use. Okay, so this is all kind of being repetitive here. Assess need for resuscitation at the time of birth. The APGAR score does not tell us whether or not we need to be resuscitating. Why is that? Well, because your first scoring happens at 1 minute. So you're going to let that baby lay there for 1 minute before you do anything? No. So we're going to resuscitate irregardless of our APGAR score. So when we walk into a delivery, they've called us to be the baby catcher. And we say that loosely because the physician is there. The nurse doesn't catch the baby, but we take care of the baby after delivery. So we walk in the room. We want to be prepared. We ask the labor nurse, is this baby term? And then if the baby is already born, has the baby tried to cry or breathe? And what's the baby's tone? So if the baby has good tone and is swinging his arms and legs around everywhere, if the baby is crying, screaming, crying, probably not going to need resuscitation. But if the baby is not crying, maybe the baby is breathing, but you're doing everything to stimulate the baby and you can't get the baby to cry, this baby needs resuscitation. And then if the baby is just limp, no tone in its arms or legs, it's going to need resuscitation. Okay. So what we do when the baby is delivered, normally babies go straight to mom's belly, and we can do this. We can rub the baby's back, dry the baby, rub the baby's back, try to get the baby crying and screaming. Okay. If we need to, we can take the bulb suction and suck the nose and the mouth, or the mouth and nose. You suck the mouth first, then the nose. And see if that stimulates the baby. And sometimes just sucking out the baby's airway will allow baby to take a big deep breath. Okay. But if we have baby on the chest and we're doing all these things and we cannot get the baby to start crying, then we take the baby immediately over to the warmer. Okay. We lay the baby on their back. We position the baby with the head slightly extended or in the sniffing position. That opens the airway. If you don't get the baby to cry or scream or take a breath there, then you suck out the mouth and nose. If that doesn't work, then you start evaluating respirations, heart rate, and color. Okay? So if your baby is not breathing, not making any attempts to breathe, who cares what the heart rate is, who cares what the color is, start bagging your baby. Okay? Positive pressure ventilation. If your baby is not breathing, you do not have to know the baby is blue. The baby is probably blue, but you don't have to then stop and evaluate the color. If your baby is not breathing, you start doing bag mask ventilation. So you do bag mask ventilation for 30 seconds, and then you evaluate your heart rate. Now, as you're doing bag mask ventilations, of course, you're going to look for chest rise. You're going to listen on both sides of the chest to make sure you hear breath sounds on both sides. And then you're going to be watching your color And if you're doing effective bag mask ventilations, you're going to see chest rise, you're going to hear breath sounds on both sides, and you're going to see improved color, okay? And then 30 seconds comes along, and then now you listen to the heart rate. So if the heart rate is above 100 beats per minute, then you decide whether or not you continue doing the bag mask ventilation. So if your heart rate is above 100, is your baby breathing? Well, if your baby's not breathing, you still do positive pressure ventilation. But if your baby's heart rate is above 100 and they're adequately breathing, then you don't need to be doing the bag mask ventilation. Maybe you want to hold some oxygen in front of their face for a little bit, but you don't need to be doing bag mask ventilation. If your heart rate is below 100, you're going to continue doing bag mask ventilation, okay? If your heart rate is below 60, now you're going to do chest compressions along with your bag mask ventilation, okay? You do that for 45 seconds or so, and then you reevaluate everything again, okay? If now NRP has changed their rules about oxygen, okay? So if we're doing bag mask ventilation, NRP says do the minimal amount of oxygen you can to adequately oxygenate the baby and get the heart rate up. So you're looking at your color, your heart rate, you put a pulse ox on, you see what your oxygen saturations are, okay? So if I use room air to bag mask my baby with positive pressure ventilation with room air, and I'm getting good chest rise, I'm getting good color, I'm getting a good heart rate, and I'm getting good oxygen saturations, I don't need to turn the oxygen on. But if I am not able to get my oxygen saturations or improve my color, then I need to start adding oxygen. If I'm doing chest compressions, then I crank my oxygen up to 100%, okay? And then, of course, if you're doing chest compressions and all that kind of stuff and you're still not able to get a good heart rate and good breathing, then we're going to start talking about intubation and doing epinephrine and doing a full resuscitation, okay? All right, now to prepare for resuscitation, if you remember from our tours into the labor unit, they have that little baby warmer section with all those drawers. Everything we need to resuscitate a baby except medications is in those drawers. Our laryngoscopes, our blades, our handles, our ET tubes, suction tubing, CO2 detector, meconium aspirator. What else is in there? Everything we need is in there to resuscitate our baby, okay? But as I go in there, I might, if I'm anticipating this baby is going to need resuscitation, I will actually pull my blade out, pull my handle out, and connect them. Make sure my light and my battery are working on my laryngoscope blade. I will pull out what I anticipate to be the proper size of the ET tube. I'll have my suction ready and turned on. I'll have my bag mask ready and turned on. I will check my pressures that I'm going to be giving this baby when I do my bag mask. I'll make sure those are appropriate. We like a PIP, a peak inspiratory pressure, to be 20 millimeters of mercury. We like our PEEP, which is our positive end expiratory pressure, to be around 5. So our PEEP, PIP, is how much pressure goes into the baby when we squeeze the bag. So that's what the pressure is when they breathe in. Okay, that's your PIP, PIP. Your PEEP, PEEP, is the amount of pressure that remains in your lungs after you have exhaled. Okay, and we want to maintain a little pressure in our lungs when we breathe out. Otherwise, our lungs would collapse, right? So we want a little pressure. So I check those pressures. I check to make sure everything is ready. I turn my warmer on. I get my bed warm because a cold baby is a sick baby. So I want everything to be warmed, and I want everybody to be on standby and ready to respond to this baby as soon as this baby is delivered. So that's your preparation. All right, now let's talk about respiratory distress syndrome. That is, RDS. So when you talk RDS, you talk S being surfactant, okay? They have an inadequate production of surfactant, or they have something that has deactivated their surfactant that they have already produced. So that would be meconium, blood, things like that. So they do not have the ability to keep the alveoli opened, okay? So so these babies are going to have breathing problems and oxygen exchange problems. Excuse me. So anyways, we want to prevent preterm birth, but sometimes that doesn't happen. So we will give mom steroids. Steroids help baby to start producing this surfactant, okay? If babies are born, irregardless of whether we've given the surfactant, irregardless of whether we've given the steroids, we may end up giving these babies surfactant after delivery. So if they have an inadequate production just because they're preterm, these babies will be intubated and they will have surfactant administered through the ET tube right into the lungs, right where it needs to be. If these babies are born, they have adequate surfactant, but they had an aspiration of some sort and it deactivated their surfactant, these babies may be intubated and given surfactant. We're going to put them on a cardiac monitor. We're going to do blood gases. We're going to continuously watch their pulse ox, and we're going to manage their respiratory distress. Okay. So ventilation, correction of acid-base balance. Correction of acid-base balance, your number one treatment for acid-base imbalance is respiratory support, okay? A compensated respiratory support. Very rarely, hardly ever in a lifetime will you ever give sodium bicarb to correct an acid-base imbalance, okay? We keep them warm. We provide nutrition at whatever way this baby needs. If this baby's being intubated, they are not eating, okay? So they've got D5 going, D10 going, or they've got parenteral nutrition of some sort. They'll be on antibiotics or they'll be on some sort of infection precaution deal, okay? Now, RDS is different than transient tachypnea of the newborn. Transient tachypnea of the newborn is just what it says. It affects the newborn, it's transient, and they have tachypnea, okay? So they're breathing really fast. So this baby is having an extended transition from fetal life to newborn life. So they're breathing on their own. Maybe they've still got some fluid. They're trying to breathe it off. During that time that they still may be having fluid, lung problems, they have to breathe really fast to be oxygenated, okay? This, we usually just support these babies with minimal oxygen therapy until they transition, okay? So that may be 1 hour, that may be 1 day. We don't know, okay? But that's usually the extent of the care these babies need, is supplemental oxygen until they transition, okay? There's nothing wrong with them. Their surfactant is fine. They're not preterm. They don't have any congenital anomalies. They're just having a transition difficulty, okay? And these are some of your babies that you can expect that to happen to, is babies with diabetic mothers, babies with asthmatic mothers, male babies. So we talk about, you'll hear OB nurses say, I know I'm going to have a sick baby. I pray it's a girl, because male babies have a little difficult time transitioning compared to the little girls, okay? your large babies, your C-section babies. These are the ones that will usually have transient tachypnea of some for some amount of time. So, you know, they still have a little bit of fluid left that they're trying to clear, okay? They will have, you know, show signs of respiratory distress, so they might have some grunting, and the grunting sounds like a little baby that's singing. It's an expiratory sound they make to try to create pressure in their lung so that they can oxygenate. Nasal flaring so that they can breathe in as much oxygen as they can. You may see a little cyanosis. They may be tachypnic for 1 hour or 6 hours or 1 day. And so it's mild, okay? It's not this big whole resuscitation thing. You just need to provide supplemental oxygen. That can be in the form of a little nasal cannula. That could be in the form of a little blow-by oxygen, just depending, okay? So it's not a big hairy deal, okay? So yeah, you can do an x-ray and diagnose this. If your baby is breathing fast enough, you may not want to be feeding this baby, because remember we talked about the coordination of the suck, swallow, breathe. So the babies may be breathing fast, so fast that they're not able to do that coordination. So we might just tube feed these babies. But then again, if you're starting to put volume in their stomach, and that volume is pressing on their diaphragm and inhibiting them from the effort that they already have of breathing, you might be causing even more problems for this baby. So this baby might be NPO for a couple hours. We might not have an IV going or anything. We just might wait and see if this baby transitions in a couple hours, and then baby can go straight to breast or whatever. But if it looks like it's going to be longer than a couple of hours, then we might start IVs and give this baby D10. Okay? All right. Meconium aspiration syndrome. This is bad. This is a bad type of pneumonia type deal. They've actually got a lung full of meconium. Okay, that's thick, tarry stuff. Now, if you've ever cleaned meconium off of a baby's butt, you know how difficult that is to do. You put that in someone's lung, and it's going to be weeks or months before they clear that. So they're going to have problems for weeks or months. So we will do everything in our power to prevent this from happening. However, it sometimes does. They're at risk. Now, if a baby has meconium stained amniotic fluid, that does not mean that they've aspirated. Majority of the time they have not, actually. This is not very common. However, depending on, you'll hear the nurses say, I have meconium stained fluid. They'll say, what is it? And they'll say it's a thin green, okay? Or they'll say it's pea soup green. So if you have a baby with amniotic fluid that's pea soup, you probably have a baby who's going to aspirate, because what that means is the meconium has been in there for an extended period of time. So the entire amniotic fluid has been totally saturated with the meconium. It has basically blended as if someone stirred that stuff, okay? So the baby is probably going to aspirate upon delivery, or if not, has already has meconium in their lungs. But if it's thin, looking like lime green Kool-Aid or something like that, then the meconium has not had a chance to thoroughly saturate everything, and this might be okay. Your baby will be delivered, and if the baby comes out screaming and vigorous, then we don't do anything. Baby goes straight to mom's chest and life goes on. But if the baby is born limp and not screaming, we take that baby immediately to the warmer and we intubate that baby so that we can visualize cords, see if there's any meconium there, and we suck it out, okay? And it hopes to prevent this meconium aspiration, okay? Okay, so this is thick stuff. So yes, it is a mechanical obstruction. We do want to suck this out. They actually aspirate this into their lungs, and it's just really bad. This causes a pneumonia. It vasoconstricts the pulmonary vessels, so you have all that kind of problem. So we may be reverting back to persistent fetal circulation. It does inactivate surfactant, so if they did have surfactant on board, it's gone. So this baby's going to need surfactant, and I'm telling you, this takes weeks and weeks and weeks to clear up. Here's your signs of distress. They're cyanotic, so they're blue. They may not be breathing, or they may just have apnea. They have a slow heartbeat. They have respiratory distress, barrel-shaped chest. You don't hear air movement. The liver may be displaced because, remember, the meconium, if it's being aspirated, it just might be sucked down into the right side of the lung. And their body and skin and nails may be stained green if they've been sitting in this for any length of time. We try to suction out the trachea. We put UVC lines in. We give surfactant, antibiotics, and these babies are in the NICU for weeks. Okay. All right. Hypoglycemia. I know I've talked about this to death. So when we do glucoses on baby, it's a heel stick, and hypoglycemia is a heel stick less than 40. Okay. Here is your babies at risk for hypoglycemia. We've talked about this multiple times. Here are your symptoms for hypoglycemia. So maybe you don't have a baby that meets these criteria here, okay? Maybe you don't have one of these babies. Maybe you have a normal term AGA baby, okay? But for whatever reason, the baby starts exhibiting these symptoms, which, by the way, can be symptoms of things other than hypoglycemia. They can be symptoms of everything else in the world, actually. But anyways, lethargy or irritability. So they're on one side of the spectrum or the other. Poor feeding, poor suck, there's cyanosis, hypothermia, respiratory distress. Tremors is a big one. Tremors in your baby is a big key one. But it's, it could mean other things. High-pitched cry. So if your baby has those things, check a blood sugar, okay? Routine screening of all at-risk babies. So if your baby falls in one of those risk categories, SGA, LGA, diabetic mother, they're going to fall under the protocol, which is we're going to check a blood glucose before every feeds for 24 hours. And this 10% dextrose IV, this is only for those babies who they're feeding, and we can't keep their blood sugars up despite feeding, or this is a severely preterm baby that's in the NICU and we're not feeding this baby. Okay, so they get the main one we use is D10. Okay, that can go through a peripheral IV. We can go up to 12.5 through a peripheral IV, but if we need to go higher with our sugar, our dextrose, then we will only go to D15. And that must go through a UVC, and we will never use anything higher than D15. Now, this is a physician decision. This is pretty rare that we'll even go past 10%. Okay, usually we can manage a baby on 10%. There's that very, 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 very minute population where we have to go to a higher dextrose. Now, the reason why we have to go to a higher dextrose is because we can do D10. We usually do a standard 80 cc's per kilogram, but if we're not maintaining their blood sugar at 80 cc's per kilogram, then we need to go up to maybe 100 cc's per kilogram. But now we're talking about more volume, okay, on a preterm baby. So volume is an issue for babies. So there's a fine line that, we can't be giving these babies too much volume, okay? Especially preterm baby. You give a preterm baby too much volume and you're going to blow their cerebral vasculature, okay, or cause pulmonary edema or all kinds of bad stuff. So volume is an issue with these babies. So that's why we would go to a higher dextrose, okay, because we need to get more sugar and not necessarily more volume, but we will never go beyond D15, okay? And then D15 has to be in a UVC. So if all you have is a peripheral IV, you cannot give D15. You cannot do it. You have to have a UVC, and if you don't have a UVC, you need to put one in, okay? If you need to go to D15, you need to put a UVC in, okay? And never, ever, ever, never, ever D25 or D50. Okay, so when we're doing heel sticks on babies to check their blood sugar, we do it on the sides of their heels, okay? And the gray shaded areas are areas that we do not want to poke, but basically we don't want to poke anything but the sides, okay? So you see those two pink marks, and I wish I was in front of you because those look like they're on the bottom of the baby's foot, but they're kind of on the side bottom, like right where the corner is from the side to the bottom. So that's hard to describe on a recording, but we definitely don't want to go on the absolute bottom, and you're just doing that bottom edge of the side of their foot, okay? Anywhere else you're going to hurt the baby. Okay, so here's a great picture. You see how she's holding that baby's foot? You see how that baby's foot is red? So she's kind of doing a little tourniquet there with her fingers. Okay, and you can see that little poke mark. It's kind of like on what you would consider the corner of that baby's foot, on the side kind of bottom edge. Okay, so that kind of sounds confusing, but it's a very particular spot, okay, so we don't hurt these babies. And we don't use those kind of pokers anymore. When you go into OB for your clinicals, please ask to see what we use to do baby heel sticks, okay? There's two different deals that we use. We use that adult Lancet that you're used to seeing in the units, but you know how you can turn the little top of that cap so it's set on the middle setting as far as the depth of that puncture. You can turn it to the farthest depth, and that's, you know, your old guy who's got leather skin that you really need to kind of penetrate a little bit to get a blood sample. Well, they have a newborn or pediatric depth. So you can turn the deal to the different depth. We also have what's called a tenderfoot, and it's the true version of a lancet, because so we are truly lancing, slicing the skin a little bit, and that's for blood draws where you need more blood. Like for blood sugar, you just need a drop. So we'll use I can't remember what those pokers are called, but anyways, we use those little pokers. But like if you have to get CBC or a Bilirubin test or do a PKU test, we're going to use that tenderfoot, which actually slices the baby's foot a little bit. So we'll show you those when you guys come for clinicals. All right, sepsis, signs and symptoms of sepsis. So you have a baby, preterm or not preterm, but your baby's getting septic for some reason. Baby's going to start showing signs of respiratory distress, and look, they're going to either be lethargic or irritable. They're going to have poor tone, so they're just going to be laying there like a rag. They're going to be cyanotic or pale. The cold, clammy skin. They're going to have temperature instability. So usually on the newborn, you're going to see a low temp, okay? So they're hypothermic, usually on a newborn, okay? They're going to start having feeding intolerances. They're going to have hyperbilirubinemia, and they're going to have tachycardia, followed by, as they start really deteriorating, bradycardia, and then death. So we had an interesting case in clinicals this week. We had a woman who was a gravida 8, para 7, so she was there in labor. So she did deliver, and she had her 8th baby. Her first baby was born in 1992, and I wasn't a nurse then, so I'm not really sure if they did not routinely test women in pregnancy for GBS status. But irregardless, she had 2 babies born in 92 and 95, I think, that did get septic from her positive GBS status, but she was either she was not tested or treated during labor, and her babies got septic and ended up in ICU. Okay, this could occur very quickly. So really important that we test our moms for GBS and treat them during labor. So you know, a baby can be born and do fine for an hour or 2 or 3 or 4 even, and then start showing signs of sepsis. It happens quick in a baby. It happens quick, and it progresses very fast. Okay, so your babies could be spiraling right in front of your eyes if you're not aware of what those symptoms are, and start intervening quickly. Okay, so there's that. I hope you guys listen to the recording, and then I will see you next week, which will be week 8, and it'll be our last week of OB, and then you guys will take your last exam, and then move on to peds. Okay, so if you have any questions about the material that you've read, or about the lecture content, please email me and let me know.